I remember this 42-year-old woman who had a small aortic root, aortic stenosis. She also had a learning disability, and we thought she's not a very active patient. She doesn't need the ROS, and in a way I regret this. So I did a mechanical AVR with a posterior root enlargement, but there was some moderate mitral regurgitation coming off bypass. So like most surgeons, we think we don't want residual lesions leaving the operating room. I went back and I repaired the valve, but I wasn't very happy with a mitral result, so I had a third run of bypass and replaced it. The patient was extubated and did very well, but on day 3 she developed some fulminant respiratory failure, which is maybe unexplained, but ultimately she died. Was it transfusion related? Was it from a long bypass? But clearly this is not an okay result. I don't think you should choose to avoid this practice, because this practice will find you. Here's a more typical case where a 74-year-old woman had an AVR with a small tissue valve 8 years earlier. She developed severe structural valve degeneration and was stuck in hospital on IV diuretics. We did a posterior root enlargement that went very well, and she went home a few days later. If you only read one paper published recently about these things, I would recommend this one from Tyrone David's group, where they showed out of 7,000 patients undergoing AVR with them, almost 2,000 had root enlargement. This is a very typical practice. I won't go into the details, but the results are very good. They showed in multivariate analysis that root enlargement is not a risk factor for a bad outcome. And this is the size of prosthesis that they implant for AVR and AVR plus root enlargement, so quite the enlargement.